Good afternoon. Thank you for joining us for today's Grand Rounds. I'd like to welcome everyone from SOFT, the support organization for Trisomy, which is having its annual conference here in the Twin Cities. We appreciate you taking the time to come and share your experience with our providers here at Gillette Children's. Today's topic is focused on advances in our understanding of the care of children with trisomy 13 and 18 syndromes, of which we take care of a lot at Gillette, including a lot of adults and older patients. And it has been a joy. I know one of my patients was pivotal in bringing it here to Minneapolis, which is really exciting. So today's session will be led and moderated by Dr. John Carey, who is the founding member and medical advisor for SOFT. Dr. Carey is also a professor in the Department of Pediatrics at the University of Utah School of Medicine. Join me in welcoming Dr. Carey.
Thank you, Tori. Tori and I had the pleasure of getting to know each other by email, discussing one of the young adults here that you guys take care of. So I'm a pediatrician and medical geneticist working at University of Utah on primary children's. Kind of have a unique lens into the trisomy 13 and 18 world because as a young faculty member in Salt Lake City in 1979, I met the mother of a 2-year-old, Chris Holliday, who founded SOFT. And together we talked about the need of advocacy and growth for this not so rare condition. And SOFT was incorporated in 1980, and I've had the privilege and honor of attending every single SOFT conference since the first one in 1987 in Salt Lake. So I have probably, without bragging rights as a physician, other than some of my physician colleagues who are also parents, of probably having seen more children older than 6 months, 1 year, 5 years, even adults into their 30s than almost anyone else. So maybe Dr. McCaffrey has been to enough meetings that anyway, we'll end that part of the discussion. But the point is that it has given me a different kind of worldview and a different lens about these conditions that, as you probably know, are surrounded by some controversy and discourse in care. We'll talk actually a little bit about that. So the outline is that I'm going to give an introduction for a few moments, kind of hopefully lay the foundation for the rest of the talks. And then we have a number of colleagues here in the front row who are attending the SOFT conference this year. And I've picked some of them because I thought it would kind of give us a broader look at some of the medical aspects. But first I will have Renee Bradley, mother and member of the board of SOFT, tell her story. Not quite yet, Renee, you have a few more minutes. About her son, Dawson. Her husband, Josh, is also here. He happens to be the newly elected president of SOFT. After that, I was thinking we would go through like infant newborn care and then like older kid management, if you will. So after Renee, Dr. Kosiv, cardiologist at Yale, pediatric cardiologist, will present. Each of the presenters will give a handful of slides, 4 or 5 minutes, just presenting one little aspect. And I hope it feels integrated, even though we're going to get these different views, because it's all giving us a different portion or one aspect of the whole picture of these two complex conditions and their related conditions. But let me begin. So our purpose, which will also be our learning objectives, is to identify the important themes in the care and management of children with trisomy 13 and 18 specifically. So of course, the learning objective is the learner will identify. I won't say that for the next one, but it's implied. And secondly, to highlight selected challenges, including newborn and cardiac care, seizures, and family support. So we will talk about each of those topics individually, and it's my challenge, but also yours as well, to kind of integrate this. The second half, hopefully, 25, 30 minutes to go, we'll actually have time for questions, comments, discussion, and so on. So as I suspect everyone in the audience knows, trisomy 13 and 18 are quite complicated and often life-limiting conditions. They're unique among, in my opinion as a pediatric geneticist, unique among any of the other multiple congenital anomaly syndromes, that is, multiple congenital conditions presenting at birth. Because of course they have a striking increase in many medically significant congenital malformations, especially the heart. 80% of kids with trisomy 13 have a structural heart defect, about 90% of trisomy 18. But as everyone here also knows, there are other structural defects that occur, trisomy 18, omphalocele, tracheoesophageal fistula, spina bifida, all in 4 or 5% of newborns with trisomy 18. But there's a long list. You just have to look at Smith's recognizable patterns and you're familiar with that list. The second sort of important aspect is that both conditions have a notable increase in both neonatal and infant mortality. So in this presentation, I'm not going to go through the mortality figures, even though that's kind of on the subline there, but many of you probably know, right now, even currently with data on improved survival, close to 50% of children die in the first week. I'm not going to have time here to say, okay, what is that a matter of withdrawal of support or the defects that might take their life? But obviously that's the second part of that question. And the third unique aspect that we know about is that all the children who do survive, do make it past a year and on, have a notable and important developmental disability, usually would be considered, in those words that are chosen, severe or profound. And so that also adds to the uniqueness of the condition among the class of conditions we can talk about. I'll have the slides also show some of our patients. Some of them were actually at the meeting. This is Carrie in both of these pictures. It was her mother, Chris, who founded SOFT. I helped her with that endeavor in 1979, 1980. We had the first meeting in 1980, even before we were incorporated. And Deb, you can't see it very well, but down on the right-hand side are the 5 original girls with trisomy 18 that came to that first meeting. We also had two boys with trisomy 13 that were not in that particular picture. And that was the genesis of SOFT and of this conference that now has been going on. Also, and as I said, what gave me this rather unique lens. So some basic premises just to get our discourse moving is that everyone knows this, the conventional wisdom that still is around but has some involvement that is going on. The conventional wisdom is to suggest or offer non-intervention, no surgery, no intensive care. Of course, that's variable, and many children do get intervention, including surgery. But that still remains kind of the conventional wisdom when you read the first paragraph of any article that you'll look up. So currently, compared to a decade ago, we have this better plan of having excellent pediatric palliative care that helps newborn doctors and specialists with presenting to families the option of we can go a comfort care route or we could go to varying degrees of intervention. So that, at least in my experience, hearing stories, knowing our hospital, that's kind of what happens. But since about 2006, when a paper appeared from Japan that demonstrated that intervention actually improves survival, since that time, there has really been an evolving dialogue in the pediatrics, neonatology, bioethics, cardiac surgery, and so on literature. And you'll hear some of the other presenters talking about that today. And this evidence actually kind of challenges that narrative of non-intervention or we don't usually do anything in this setting type narrative that is around. So as I said in an editorial a few years ago, the paradigm is changing. And in fact, evidence for this that goes into the story of data on increased survival that happened since 2016. More data on cardiac surgery is also data. Dr. Wilfon in the first row is a co-author on these papers, where a large survey was given to over 300 families off of social network. Data emerged that showed that those who filled out this survey, almost to a person, felt that their child, albeit challenges of medical complexity, survival, and the rest, their child gave them joy and had a, quote, good quality of life. That was the way the question was actually worded. And here are two of Dr. Janvier's 4 papers, the one in pediatrics being what I would consider a seminal paper, one of the first works that give us some sense of what we might say, well, what do we know about, quotes, quality of life? So here's a collage of children I've cared for, that I still care for. Some of them are at the meeting this year. The 6 pictures here were on the cover of a special issue of the American Journal of Medical Genetics in 2016, devoted to trisomy 18 and 13. And so to summarize, just to summarize the data that I didn't present to you, but at least I'm touching on, is that the range early on and now is that 3 to 13% of children survive to 1 year. The latest study is saying 10 to 15%. And in fact, most of the children that survive to a year survive to 5 years or 10 years in 2 recent studies. 1 year survival with intensive intervention from a study done at Cincinnati Children's and another study in Japan suggests that with intensive management, including surgery, 35 to 50% of children survive to a year, using year as a landmark. Also, in the way of summary, children do progress in their developmental milestones, albeit slowly, and with the disability as alluded to. And of course, parents should be part of decision making, and in modern years, a shared decision making model is certainly what I would recommend. So I'm going to stop at this point for my introduction. I went 3 minutes more than I expected. I'm going to invite Renee Bradley to the podium, and I will move to your first slide. Is that okay?
Yes, sir.
Start with that, and then you can use the mic or not. I think we project pretty well.
I'm pretty loud.
Is the mic better? Would you rather have the mic?
Yeah.
Okay. Looks like so. Here's how.
Okay.
You can also advance there too. But
Okay.
anyway.
Well, thank you, first of all, for having us and allowing us to come in and speak with you, and for your valued time. We really do appreciate your time being here. So my name's Renee Bradley, and my husband is Josh. As he said previously, Josh was just named president of SOFT after a 30-year term for my previous president. So, but we have Dawson that is 18 years old. These are the pictures that we originally had from the NICU. Is the one on this side is Dawson the day after he was born, and to the right is after his first heart surgery. So Dawson was born, sorry, I have to get my notes up. Dawson was born with no prenatal diagnosis of trisomy 18. It was just determined that he was going to be smaller. Didn't really go into detail with abnormalities or anything. He was born at a very low birth weight and was in some respiratory distress. At that time, they took him directly to the NICU, and there were some early markers that determined it was a possible diagnosis of trisomy 18. Blood work was done, and we met with cardio and geneticists, and the diagnosis of T18 was confirmed at 2.5 weeks. At 1 month old, Dawson was a happy little boy, loved smiling at us, never wanted toys, just wanted to look at our faces. He was the first child, so he is spoiled rotten. He only knew Josh and I and loved it. We lived about 500 miles from our parents, so we were it, and so he loved us. You know, that we made him love us. We, after meeting with the geneticists and so forth, we went home, and he thrived. At about a month old, he went into congestive heart failure, and we went to the hospital. very random story of that there was a hurricane in Tulane, and the leading cardiothoracic surgeon happened to have to come to Le Bonheur for to finish his what I don't know what you call it, the fancy words, but anyway, he was there, and he said to our cardiologist, let's just do the repair of his VSD and ASD. He had a small PDA and large VSD. And she said, I don't think he's strong enough. We're leaning towards a PA banding. So at that time, a PA banding was done, which allowed him to thrive and get bigger of what they were hoping that he would. And we decided, with all the things that you see, we found soft, just a random, we go downstairs on the computer and Google Trisomy 18, which I would not suggest that to any parents that we're talking to now. But we found soft, contacted them. They told us that, our kids do survive. So at that point, we decided it was best for us to move back home so that our family could get to know Dawson and Dawson could get to know our family. So we moved back to South Carolina. I did say that at the beginning. We're from Greenville, South Carolina. And we have 3 other children, 11, 16, and 9. So, and he began to get stronger and stronger with the PA banding. He would take some, he would drink from a bottle somewhat, but it was eventually determined that he had some obstructive sleep apnea where a tracheostomy was placed, and then he had a G-tube placed, which allowed him to get even stronger. At 18 months, he had gotten up to 8 pounds, which was a goal for us. And we went to the Medical University of South Carolina where he had his ASD and VSD repaired, and his PA band was removed at that time. So after that, we are going to in USC, which is about almost 4 hours from our home in the upstate of South Carolina, and we were preparing for 2.5 weeks there. He went on Thursday. Friday we had surgery. On Monday they're like, "You ready to go home?" So a child with trisomy 18 did a weekend heart surgery. That's my superstar. So we went home, and so this was after his first his VSD, ASD repair. The pacifier is bigger than his mouth, bigger than his face almost. So we went home and had numerous surgeries. He was decannulated at 22 months old. Has continued to thrive with that. He does need some support at night just because of the obstructive sleep apnea. We have a wonderful pediatric sleep medicine doctor in the upstate of South Carolina that went to bat for us numerous times to say, hey, he's just having trouble at night sleeping. And so low pressure of CPAP since then. At 4, he started having seizures. He had partial complex to begin at the beginning, and then started tonic-clonic seizures, which have been our biggest struggle. He was then diagnosed with Lennox-Gastaut after that, so numerous medication trials, but for a kid that went from 30 seizures a day down to, after placing his VNS, went to 6, and then fish oil. We were on a ketogenic diet, went to fish oil, cut down to 3 a day. So he still does have seizures, but they're very brief, less than 30 seconds, and recovers great after those. This first picture where he's smiling so big, this is 1 day post-op after major scoliosis surgery. We had not really heard him laugh probably in about a year, I would say, and after his surgery, we took him all, he was take the tube out, and about 2 hours after this, he was on his CPAP for an hour, and he bust out laughing on his CPAP. So I'm like, Josh, is he having a seizure? And he's like, no, he's laughing. So we take it off. We've got video of him laughing. So happy little boy. He's continued to do well, even after the scoliosis repair and VNS implant. Dawson's a happy young man, loves his family, and brings us pure joy. Our journey has ups and downs, but we are grateful for every single moment that we have with him, and we celebrate the beauty of his life. And the picture to the right is him in his favorite Clemson Tiger orange, and he is 18 years old. He turned 18 in November, and he is the joy of my heart. So thank you again for allowing me to be here. That's just a little bit into our life with Dawson.
So thank you, Renee. That kind of gives us some foundation. So we're going to kind of move through specific issues like early infant care. And I'll invite Dr. Katya Kosev to come and present as well, except I went backwards there. And Katya is a pediatric cardiologist, assistant professor of pediatrics at Yale, and a great and deep interest in these conditions.
Hello, everybody. Thank you so much for inviting us, and we have a beautiful hospital. I'm like really jealous. All right. Yeah, so I'm a cardiologist with an interest in fetal cardiology, so I'm often meeting families at the time of prenatal diagnosis. And I became interested in trisomy 13/18 really from the standpoint of, the kind of should we be doing heart surgery or not. So this paper was really like the first thing I ever read that sort of bucked the traditional thought that children weren't going to survive. So this was published in 2016. This was a study out of Ontario, Canada. It was published I think it was published in JAMA, not JAMA Peds. And it talked about the impact of medical and surgical intervention. And so, the median survival at 1 year for those that were, that they evaluated was around 70%, which was just like totally unheard of. And then, reflecting out past that, obviously, it was much higher. So that was kind of like really just like earth-shattering to me. You're taking everything as gospel, that you're learning, and then, you realize like maybe we don't have it all figured out. So the historical precedent, I guess, is that you shouldn't operate, you shouldn't do anything. Intervention is futile. We should just do comfort care, i.e., we shouldn't really be offering much of anything. These children have very significant morbidity and high mortality. If we're we look back to like when things that were published here in the United States. Actually, Dr. Carey gave me this article by Van Dyke. It was a case series. And it was really interesting to read this because with one of the cases at that time, one of the children had undergone heart surgery, had a VSD repair. And when you read the case, it's not like the typical, I feel like scientific literature, it's very dry, but it like talked about these are the milestones that this child reached. And I just thought that was really poignant to, again, like, give a story behind just the main scientific facts. In 2004, there was Eric Graham from MUSC published a case. It was actually it's from a database, but this was also like one of the first studies that said, hey, of these children that had heart surgery, 90% of them survived to discharge. And this was a critical care database. Then in 2008, and I might have gotten the date wrong, it might have been 2006, but Kaneko published a study in Japan looking at 3 different errors of management. The first being no intervention, then PDA medical closure to surgical repair. And there was a significant change in terms of survival. So, I think that there's enough out there. Like, there's enough out there to question the clinical management. And so I think that's why we saw this sort of increase in the number of surgeries that were being performed. So at the top of this slide, there's the Graham study with that evaluated patients in the Pediatric Cardiac Care Consortium. And so we got 35 patients, right? Then this other study from Japan, 38 surgeries. So let me just clarify that. So the first one, 35 35 patients total who had operations. Then the Japanese study, 38 patients. Then there's this study in, I think it's 2017, Peterson, also reviewing the same database, Pediatric Cardiac Care Consortium. And now we're up to 98 patients over 27 years, so that's a long time. I actually use the Pediatric Health Information Systems database to, again, look at patients who had undergone heart surgery. And we had about 1,400 patients in total with trisomy 13, 18 that we had information on. And there were 123 index operations over a 12-year period. So you can see it just keeps going up. And then the last study that I think is worthwhile reviewing is a study by Cooper, who this group utilized the Society for Thoracic Surgeons Congenital Heart Disease database, which most programs will provide information to. So here we have 343 index operations over an 8-year period. So we have more operations happening per year. My study was about 7% of patients with congenital heart disease who had operations. I'm not sure what the percentage was in the Cooper study. I want to say it's almost similar. I don't know if you remember, Jim, but so anyway, so we're seeing increases in the number of cases being performed, but there's still a lot of hesitation. So this isn't like okay, everybody who's being presented is moving forward with heart surgery. And one of the questions was, well, what difference does it really make? So maybe the survival. You'll improve survival for a couple weeks or a couple months. And so in that same phys study, we looked at readmissions. And so we really can't comment on like out-of-hospital mortality, but we can comment on in-hospital mortality. And the dark line shows the survival in those with heart surgery, and the dotted line is those without heart surgery. And you can see there's a pretty stark difference. And that difference, we did look out to 2 years. We were able to reevaluate the same patients. And so that survival advantage persists. And you can kind of see that once you get past sort of that initial period, it really does stay pretty level. So, but for just to kind of give you an idea, what does that survival advantage look like? So there was a reduction in risk of 64% trisomy 18 and 45% trisomy 13. So I think those are not numbers to sneeze at. Here's a really strong study. Again, the Society for Thoracic Surgeons is sort of our main database warehouse for information. We're looking at risk and mortality, and how we should think about cases. And so their study showed that 70% of participating centers performed heart surgery, and it's going to be different in terms of the number of cases at each center. There were definitely certain centers that did more. Survival after heart surgery was about 85 to 89%, and that's compared to 97% in non-syndromic patients. If we look at, so we talked about the survival. So mortality rates were around 11 to 16%. In terms of postoperative complication rate, they were pretty high. I mean, 58, 56%, which compared to the let's say non-syndromic patients, or all, I should say all patients. I'm not sure if it's non-syndromic. It's about 36%. So, this is more complicated. It's more. It's going to require a longer post-operative course and may have more complications. Many of these patients do have G-tubes, about a quarter of the population. Within the trisomy 18 population, about almost 50% will have non-cardiac issues that also need to be considered. And so this question about, okay, these are complicated patients. They have a lot of medical needs. They're not necessarily, we shouldn't be treating congenital heart disease in a silo. So we were really interested in then predicting survival. So like, who's the best patient? Who's the person that we really want to take to the operating room? And I think we came up with a decent model. I think it deserves some more attention, and hopefully we'll have the opportunity to do that in the future. But we did look again at like survival predictors, and we saw, that having a G-tube was definitely predicted survival, and then also that cardiac surgery did as well. And so what's interesting though to me about cardiac surgery is these graphs look at the impact of time, and so the improvement in survival from cardiac surgery or from getting a G-tube doesn't vary with time. And so for heart surgery, this is important because children may become symptomatic early in their lives, 1 month, possibly even younger than that. Sometimes it's delayed because of other medical issues such as pulmonary hypertension. But there is a notion that we should delay heart surgery until a child is bigger, until a child has proved that they could survive, that they're not on a ventilator. And I don't know if that's necessarily a good thing, but I think that's still, something we're trying to understand better. So this brings me to this next slide, which was a recommendation statement or a guideline statement that was just published in May, and this was led by the American Academy of Thoracic Surgery. And I had the distinct honor of getting to be a part of this group and review what's available and help physicians, families, healthcare providers to have some set of guidelines that they could refer back to. And so we felt that surgery was reasonable, especially for things like a VSD or a PDA, that timely repair was appropriate, maybe not even doing a palliation like it sounds like Dawson may have had, but maybe even moving forward and just doing a full repair. We did have a lot of concerns maybe about very complicated surgeries or a single ventricle physiology. And we also felt that, excluding cardiac surgery because of other non-cardiac issues, wasn't something that we should do in totality. We also thought about infants who were on ventilator, and we didn't think that that was necessarily prohibitive, or that children who had lung disease should be prohibited from surgery. So I was really, and what I left out here, and which I think is important at the place that we're giving this presentation, is that we really need to work together, right, to take care of children who have complex medical needs, like children with trisomy 13 and 18. So, involving, being a part of a multidisciplinary or an interdisciplinary group is going to be vital in taking care of these children. So with that, I'll conclude, and I'm not sure who the next speaker is.
Jeffrey.
Oh, okay. Thanks.
Thank you, Katya. So our next presenter is Dr. Marty McCaffrey from University of North Carolina, professor of pediatrics and neonatologist, will give us some additional perspectives of care, especially of younger infants with trisomy 18 and 13.
Thanks, you guys. Thanks for having us. It's a real privilege to be here. I'm up here really for two people who got me to this point and got me interested in this trisomy journey. And it's not just a trisomy journey for me, but it's also a journey into prenatal diagnosis. The first person up here that you see with the Seriously shirt, that's my 23-year-old daughter with Down syndrome. So Shay was born back in 2000, and she brought me into a world that was obviously interesting to me as a neonatologist, but became a real part of my life in terms of how she was going to be raised, what was going to happen for her, what opportunities were available for her, and a whole brave new world, for sure. And her shirt, I think, is really sort of predictive here, because Shay and I traveled to DC. We're right here. So if you're looking on the other side, we're right behind the speakers, Congressman Trent Franks. We're at a press conference talking about the impact of the Affordable Care Act on kids with special needs. And so Shay and I were invited to go there, and I spoke. But perhaps the most important thing was that we met this woman right here. So the woman on the very edge of your picture over there in the white top, a woman named Barb Farlow. And surrounding this group, all these invitees were families and parents with kids, many of them who had children with trisomy 13 and 18. And at the time, as a neonatologist, I had spent my career as a neonatologist, as a general pediatrician, telling parents that these were children who were incompatible with life. And that they were not going to survive, and sorry about this diagnosis, but we're going to talk about comfort care. And this just opened my eyes. Now, I went through this crowd and spent the day with Barb Farlow, who's going to be critical because she was someone who John mentioned earlier, went on to publish numerous articles about the patient experience related to trisomy 13 and 18 and the parent experience related to trisomy 13 and 18. And I said, Barb, surely these people cannot have kids who are full trisomies. I mean, they must be like mosaics or something. And she's like, no, you do not know the literature. I mean, what is in the textbooks, what's in Smith's, which John referenced, is simply not really the full picture. And many of these kids can survive. And so I left that meeting and went home. And the Smith's edition that I had on my desk at the time was an older edition, I must say. Sorry about that. But it was the 4th edition in 1988. And I'll point out what they said about trisomy 18 and 13. This is in the sense of prognosis. 50% die by 2 months, 10% survive. They're mentally defective. Once the diagnosis has been made, the author recommends limiting all medical care for 18. For 13, it is the opinion of the author that no medical means should be utilized to prolong the life of individuals with this syndrome. And that sure isn't what I saw in Washington that day. So I started looking at the literature, and this is an article that came out in 1994 that talked about survival for children with trisomy 18 and 13. And similarly to previous articles we just talked about, these were families that were invested and really insisted on care for their children. And you may say intensive care, but you have to be very careful when you read this literature because intensive care is in the eye of the beholder. So intensive care doesn't always mean intubated, ventilated cardiac surgery. There's some journal articles out there where a feeding tube is intensive care. So you got to be careful about that, but I'm looking at survivals here of 40%. And that is not what Smith's was reporting at the time when I was up in DC and at the time when I was taking care of these children. So follow along and go down the timeline here a little bit and starting to work more in this area trying to support families. And there are a couple of really, I think, interesting publications that maybe answer some of these questions about why we're at where we're at. So this is a survey of obstetricians that was done by Dominic Wilkinson, published back in 2014. And it asked some critical questions because we're going to ask obstetricians these questions and then ask neonatologists the same questions. And you figure neonatologists, they're not surgeons, they're kind of pediatric people, they're kind of soft, right? The answers will be different. I'm sure they will be different. So let's see. So, is T18 a lethal abnormality? 85% of obstetricians say yes. And this is obese in New Zealand, in Australia, and in the UK. All right, we got the lethal thing. Is it incompatible with life? 54%. Hold on. I mean, so 85% lethal, now we're down to 54% incompatible with life. What happened to the other 30% of people? Let's ask one more question. Is it compatible with the child having a meaningful life? That's what this is about. It's about, is your life meaningful? So it's a little bit about a judgment about the quality of life, ain't it? Because you look here and only 8% say a child with this can have a meaningful life. All right, we got to work on the obese. What they're thinking is the care is not futile, the life is futile. So let's try the neos. Let's ask them the same questions. Is it a lethal condition? 83%. That's pretty close to what the obese said. How about, is it incompatible with life? Only 45. I mean, we lost 40% there, so 40% go from it being lethal and incompatible with life. So, all right, drum roll please. Is it compatible with a child having a meaningful life? And only 16% of neonatologists say that this is a meaningful life. So once again, it's not necessarily, certainly for at least 40% of the neos, that the care is futile, it's that the life is futile. So, what are parents told? And I mentioned Annie Janvier here, Barb Farlow here. Annie Janvier is another giant who's been working in this area, talking about the family experience. And then Ben, who's sitting here, I mean, was the lead author, or the senior author on this article. But what are parents told? And 94% are told that their baby would likely die before at the time of birth. 88% your baby won't live more than a few months if they don't die before birth. The condition of their baby was lethal, 93%. And then 61% of parents reported feeling pressured to terminate the pregnancy. What we are typically shown in Smiths is these pictures here. What we rarely see here is the collage that John also showed, that Barb Farlow put together about what these children are like as they grow and they're integrated with their families. So a little more thought about this. I mean, you know, why are we at this point where if some of these kids can survive 40% at a year, how do we have this 5 to 10% survival rate going on? What is that about? So Annie Janvier, again with Barb Farlow. I mean, the woman is amazing. And Barb's story is that she had a daughter, Trisomy 13, Annie, who survived 2.5 months. And then she had some questions about everything that happened, and she became a huge advocate for the trisomy community. And then Keith Barrington. So Annie and Keith are both neonatologists up in Canada. Unbelievable folks, brilliant people. Palliative care for trisomy 13 and 18. So they looked at 261 parents and 216 kids. And what they looked at is what is palliative care if it's with a prenatally diagnosed baby or with a postnatally diagnosed baby. How do those things look different? And they looked different. So what they found with prenatal diagnosis was just warmth, skin-to-skin care, medications for comfort, which we all know are narcotics of some sort, which also may suppress breathing, by the way, and then bereavement or psychological support. With postnatal diagnosis, if you're not getting diagnosed till you're 6 or 8 or 10 days old, a lot of things are happening, and the baby's been alive, and so you morph into palliative care that's very different. There's various interventions. It may include oxygen, may include intravenous fluids, TPN, a whole host of things. So all of those may be going on. And what Annie et al. Found is that prenatal diagnosis was the strongest independent factor negatively associated with the life of the baby. The factor most highly associated with dying in the hospital was prenatal diagnosis. And why would that be? Well, because palliative care for these kids was different. The palliative care for prenatally diagnosed children was just this. So with a baby, when all you do is give them warmth, skin-to-skin care, medications, and psychological support, what's going to happen? Very often they die. Because these kids will probably need some range, possibly, of medical support if they're going to survive. And what ultimately their conclusion was is that this is pretty significant statement, I think. It seems palliative care for children with prenatal diagnosis is directed to a goal of having as short a survival as possible after delivery. And it seems to us that neither universal imposition of comfort care or intensive care or invasive surgery is appropriate. So what I have taken away from this is really what we need to be doing and providing for families in these situations with a prenatal diagnosis is providing informed consent and letting families know what the possibilities are. And I think it's gotten better, but I'm not sure we're as good at that as we should be because of our own biases. So how have things changed? So here's Smith's again. This is the current edition. This 2021. What do we have to say from Ken Jones and the folks at Smith's? Once diagnosis has been established, limitation of extraordinary medical means for prolongation of life should be seriously considered. However, the personal feelings of the parent and the individual circumstances should also be taken into consideration for Trisomy 18. And then on Trisomy 13, because of the severe brain defects these children may have, limitation of extraordinary medical means to prolong the life of individuals with this syndrome should be seriously considered. But we should also consider on an individual basis the family circumstances. So I think things have gotten a little bit better, but things have kind of stayed the same as far as this premier gold standard textbook for us in pediatrics, and certainly in neonatology we use this on a very regular basis. The references that are used in this 2021 edition have no survival reference that goes beyond 2003. So all the data that you've previously seen, most of which was after 2016, is not even included as references in here. So I think why we're all here, I mean, I think we have some great opportunities to really improve the care that we do for these children. We're going to be launching, hopefully under the leadership of Ben Wilfon and John Kerry, an organization that's really going to pioneer some great things, I think, in terms of where we need to go, number one, with needed research. There's so many questions to ask about these kids, how their pulmonary circulation works, when to time their cardiac surgery, can we get babies home with obstructive airway disease, on CPAP, which we don't do really well in this country, but we do better in Europe and in other places. And recognizing that we've always talked about central apnea in these babies, but honestly, a lot of their airway issues and their apnea is obstructive apnea, which we can treat if we decide we'll look for it and we want to treat it. I think all of us being here, getting together and educating each other, and I think the SOFT conference, those of us who attend, we learned so much from each other. Educate providers, we need to educate parents. I will tell you, Shay's shirt that says seriously, when I look at that, what it means to me, are you serious? You learned nothing about the way you all treated people with Down syndrome into the 80s. Seriously? Get it together and do it differently. And the people that made these changes were parents. It wasn't us. We were dragged by parents to treat Down syndrome cases better. It wasn't us. I think we need to really focus on informed consent. I mean, there's some life issues mixed in here, but honestly, for me, I think parents with a prenatal diagnosis need informed consent to understand what the potential choices are for their baby. And they should be presented at least generally on equal ground. What we often do now is certainly there's going to be abortion that's going to be offered for prenatal diagnoses here. Occasionally there'll be perinatal hospice. Rarely is there stabilize and evaluate your baby, and let's see what happens. I mean, that is not a default for us at all. So I think we need to work on that. And then there are organizations out there like SOFT, but other organizations that will work with families to try and walk them through this journey. I just put up a plug up there for one of the groups I work with, which is Be Not Afraid. But I think what we have to realize, especially with prenatal diagnosis, is the day that mom gets that prenatal diagnosis, the trauma begins. And it is a very, very difficult journey. And we in SOFT, I think, have been really good at trying to work with families after the babies are born. But I think it's really important for us all to really be thinking about prenatally what is happening, what parents are hearing, what they're told. Because by the time they get to a NICU or a PICU or the pediatric floor or the general pediatrician, there has been a lot of trauma that has happened to these folks. And they may have lost a lot of trust in the system based on what they've been told, but what they see out on Facebook, in soft groups, and in other places. And just to end, I mean, I think these are absolutely lives worth living. This is just a group of the kids that I've had the pleasure to be involved with or to know over the years. And honestly, I think these kids are here with a special purpose. All of us, each one of us here is here with special purpose. But these kids are different. They are missionaries, and they are here to teach us how to love.
Thank you, Marty. So one thing is clear is that our enthusiasm, we're going to go beyond 1 o'clock. So I respect those who still have to feel like they have to leave at 1. We have no troubles staying past 1, but I know if you do have to leave by 1, I don't know whether Josh, all the slides are available for your colleagues.
They will be, yeah.
Yeah, so that anyone who does have to leave close to 1 we still have 3 speakers to go.
Yeah.
And also, Josh, you set up a room for us for after this is it here?
Yeah, we have extra time.
Yeah, so we're going to be here till 1:30. We have to go back to the hotel. We actually have a clinic at the hotel, so we do have to go back to the hotel a little after 1:30. But and so for Tori, we can still have a chance to talk a little bit. But so Glenn is next. I think I'll make sure I got the order properly here. Whoops, going the wrong way here. Yes, Dr. Green, University of Michigan, otolaryngologist with also a deep interest in trisomy 18, just to give you a thought. So Megan will go next talking about seizures, and Dr. Hamill, a cardiac surgeon who's operated on many children with trisomy 18 will follow. So we'll keep going, and we appreciate if somebody has something they have to go to.
Yeah. So it's, I've got a really short, brief presentation here. There's some important points that I think I'd like to make at the outset. When I first was asked to treat a child with trisomy 18, they were an older child, and I'm like, okay, here's what I would do normally to help a kid. That I take care of a lot of kids with very complicated rare syndromes, and I had taken care of this before, and I'm like, okay, here's what I normally do. I do sleep endoscopy, identify where the problem's coming from. It ended up being due to a small jaw, did a jaw distraction, sleeping got a lot better. Everything was much better for that child that was 2 years old at the time. And then I started getting a lot of referrals from kids and neonates that had trisomy 18, and I started getting involved with a lot of their care. And I had this kind of reluctance because I was aware of this like poor survival, but I take care of a lot of kids with anoxic brain damage and other things where the kids are really in bad shape, but the parents want to go and pursue care, and it's meaningful for them, and I'm willing to go and help them on that journey. The kids with trisomy 18 and 13, and especially the kids with trisomy 18, they're different, meaning that these are kids that are happy most of the time. And if a kid with trisomy 18 is not smiling and it's not comfortable, if they're in respiratory distress, it's because they're in respiratory distress or there's something going on with their child. And so they really do bring a lot of joy, and we don't need to have, but my own son is autistic, and my daughter, who is normal, she's not happy all the time either. And we don't need our children to be happy to have them be meaningful parts in our lives. But with that comment being that you saw earlier, the mention of the meaningful life of trisomy 18, there's a lot of happiness that these kids have and meaning that is brought into them. And we were having a discussion last night on how even after the children pass away, that they still have meaning for the families. And the time that they had with their kids is time that they loved and had impact, often decades afterward, on the families, in positive ways, in ways that I would not have predicted as otolaryngologist or a medical person. And one of the blessings as an otolaryngologist is that I get to follow these kids long term. So I've got 40 kids that I personally follow, have been following for a while. A lot of them are getting older now. And so it's nice to see these kids and how they develop and what kind of problems. And right now the things that I'm working on are how can I help these kids communicate better with their families? How can I help them develop better communication skills, whether through eye gaze devices or soundboards with limited amounts of language, and the importance of like hearing. It used to be, trisomy 18, they're going to die, no need to even check their hearing at all, no need to do anything from a hearing standpoint. But then we say, okay, if we can really generate long-term survival and help these kids live longer, how can we make sure their hearing's good? And a universal thing that these kids have, that I've never met a child that did not love music. And it's like, okay, I don't even ask if they like music anymore. It's like, what kind of music does your child like? And it's like, oh yeah, they like. See, the last one was Taylor Swift was a Swiftie. It's like, okay, I understand that. So when we have there's just from a medical standpoint, there's a couple things that I wanted to make, which is when do we evaluate a kid for obstructive sleep apnea? This is something that's been ignored for a long period of time, and airway problems are very common in kids with trisomy 18 and 13. Now there's not a NICU here, you're mainly seeing like young children.
Yep.
That have been able to go home, would be my impression. And so they're coming back into the hospital with illnesses. And okay, so when do we evaluate for obstructive sleep apnea? If they're coming to you as an outpatient, then it's do they have snoring or stutter? Are they posturing or stretching their neck out? Do the parents notice pauses in breathing or gasping breathing, retractions? And are they undergoing general anesthesia for some other reasons? These are all reasons to evaluate the airway. Now you look at this list, this is like, yeah, that's not surprising, but when we say, oh, this is a kid with trisomy 18, that frequently gets ignored and say, oh, this is, we were having talking to patients earlier today, and a kid just had his neck like this the whole time, and you go, and had some subtle retractions. It's like, okay, this is what obstructive airways look like in any other kid, and it's just very frequent in this population. So how do we evaluate? Observation and auscultation, so listening to the neck and hearing if you hear stutter or noise in the neck. O2 sat monitoring. And for parents at home, a lot of times they're getting outlets, and so they're coming in with data saying, oh, my child's desaturating. And sleep study is a gold standard. And so anybody that has something that looks like they have sleep apnea or they have craniofacial abnormalities, and a lot of these kids do then a sleep study is in order. And I think a universal sleep study, at least once, the rate that we saw of obstructive sleep apnea in these kids was 70%. Mostly severe. And a lot of times in kids where it was not suspected beforehand. So it's higher than Down syndrome, where we do right now do routine sleep studies. So I think doing at least one routine sleep study sometime for a child with trisomy 18 or 13 is very reasonable. If there is obstructive sleep apnea, or there is obstruction, so this is a kid that's maybe in the ICU or coming in ill with all these retractions, then what kind of evaluation can we do? It's after they get well, then it's doing the drug-induced sleep endoscopy, which is where we have them go to sleep in the operating room with medications, put a camera in their nose and identify the sites of obstruction. but also making sure to look down into the bronchi to look for tracheomalacia and bronchomalacia, which are extremely common in these kids. And then inspiratory and expiratory CT scan of the airway can also be extremely valuable. So of kids, of the total population, 48% had of obstructive sleep apnea. That's 70% of kids that had the sleep study. 2 with moderate, 12 with severe. The median apnea-hypopnea index was 31.8, so 3.1 to 83.4. So pretty significant. Things that we should especially should be looking out for in a kid with trisomy 13 or 18 that's intubated. These are things that are going to be related to the bronchomalacia, are persisting retractions or sudden death episodes. The sudden death episodes are typical of malacia, but it's not really put in the literature that much, but we see extremely severe malacia for some of these kids. And so the key is doing a PEEP titration where you put a scope in, take a look at the bronchi and see how much PEEP needs to be delivered to treat that malacia. If these events are present after intubation, then mandibular distraction or tracheostomy are not valuable because they do not go and deal with the distal airway at all. And so that's where consideration for PEEP, a backup rate, become important. And so just as a story of the impact that this can have, there's one family that had a familial trisomy 18 related to a translocation, just like translocation Downs. They had translocation trisomy 18 and had multiple other people in the family that had passed away. And we had a child that we were able to diagnose the malacia. We treated the malacia, and that child's now 6 years old and is the only surviving person that had this. So the lethality is definitely there, and with effective treatment, you can change the course for these families. And then just to emphasize, these kids are happy. And they want to be treated as individuals, and I'm grateful for the interest. The families are, one thing that you might not appreciate as much that we get to hear all the time is how grateful these families are for people like yourselves that are taking care of them and that listen to them. And so I just want to convey that gratitude that a lot of times a parent in extremis isn't as good at conveying to you guys.
Thank you, Ed. And let me introduce Dr. Megan Candy, colleague of mine at Bradford Children's Hospital, professor of pediatrics, University of Utah.
Thank you, John. I'm a general pediatric neurologist in an era of high subspecialization, but that allows me to be a headache doctor and also be a person who has an interest in genetic epilepsy. And thanks to John, I've been able to continue to do that with various genetic syndromes over the years. And it's been a pleasure. And just to echo what Glenn was saying about how great these families speak about their therapists and their ongoing care providers, that's the thing that's really affected me today. I've actually saw 2 different families that I had seen early on in their journey with trisomy 18. I saw them again today for the first time. We didn't realize that we knew each other. And the things when I was just kind of catching up with them, the things that they lit up about were this one home health nurse or this one therapist that had gone out of their way, spent the extra time, tried the extra thing. And so yes, everything everyone's doing matters. So John invited me to get involved. So I guess my involvement in trisomy 18 specifically came up because John invited me to join a group of people looking at a database of patients with trisomy 18, and so I'll get to that. But just initially wanted to talk about some of the neurological issues that happen in trisomy 13 and 18. And some of the families that haven't seen a neurologist, interestingly, have been saying, why would we go see a neurologist? So there were multiple families today that had not seen a neurologist before, which is pretty cool for them. And so things like seizures can be the first time. So there were also families today where no one actually had been doing any investigation prior to their child having seizures, maybe at around 5 months of age. And then, of course, retrospectively, oh yeah, they had, distinctive hands, or oh yeah, they were a little floppier, or things like that. But sometimes seizures can even be the first symptom of something going on. Brain malformations much more common in trisomy 13 than in 18, and a whole variety of things can be seen. Certainly oromotor and airway dysfunction, which has already been talked about, and then floppy muscles, contractures, dystonia, and developmental delay. So the project that I became involved in was looking through the Tracking Rare Incident Syndromes database, looking at parent surveys from 2007 to 2021, where there were 186 surveys from parents of children with trisomy 18, and using this database to try to get a sense for the prevalence of seizures. And so it was great to have that many surveys to look at. The things that we interestingly found out were that brain malformations did not correlate with seizure. So in general, when we see a patient with maybe an unknown diagnosed genetic syndrome or just a new patient with seizure, we often do an MRI as the first test. And we use that somewhat to guide us. So if something's abnormal, we might not even do genetic testing, or maybe that used to be the case. Or if it's normal, then we might say, okay, let's go to the next thing and do genetic testing. But it was interesting in the population we looked at that having a brain malformation didn't necessarily increase your likelihood of having seizures, which is not what I think of in the general population. So using a database for a study, it's going to be limited because it is retrospective, because I think we all have met families where what they tell you is so different than what is in the note. So what their understanding of what was being or trying to be conveyed is very different. So it's based on family report, and that can be challenging. But we were able to, get some numbers. So found out that 30% of that population that was surveyed had experienced seizures. About 12% of them had infantile spasms, which are a specific type of seizure we often see in kids between 6 and 10 months of age, for a variety of reasons. In genetic syndromes, in people with tuberous sclerosis, of course, is much more common. We have cryptogenic causes where we don't necessarily know why, but it's a common type of seizure. And I would say of the families I met today, many of them had seizure onset around that age. Not necessarily clear as to whether or not they were told they had infantile spasms or not, but I have my suspicions. And then 50% of the group that had infantile spasms went on to have epilepsy. Also today only, recall bias, recent recall bias, many patients didn't have seizure till their late teens and are now in their 20s and 30s, so that's interesting too. And so a lot of families, when we try to anticipate, will say, well, when are seizures going to start? When will they stop? If we're good by age 7, are we good forever? And we don't know that for sure yet, of course. A variety of seizures were seen, so everything from generalized focal or mixed seizures. I think today, in talking with families, it seems like a lot of them have multifocal epilepsy, which is common, meaning that there are multiple areas of the brain that are kind of misfiring that could start off different types of seizure. Seizures overall were more common, again, in people with infantile spasms, and in this survey, in people who had central apnea. So really hard to know, were people apneic because of seizure, or, chicken or the egg kind of thing. And so that's interesting to note. A broad spectrum of seizure medications were trialed, as is often the case. There's a lot of trial and error that goes into finding the right seizure medicine for your child, for their seizure type, that is not going to have adverse effects that you are trying to avoid. And so the things that came to me and being involved with this database study were, wow, we need to really figure out a lot more about kids with trisomy 18 and what happens with seizure. We should probably do the same thing for patients with trisomy 13. We had some good debate yesterday at a Q&A about when and if we should be doing baseline EEGs. What would we do with that information? Is there even a phenotype, or is there a specific EEG finding that we're going to know is the case in patients with trisomy 18, as we do in some other genetic syndromes? We don't know that yet. And so in order to figure these things out, we need to invest more money and time and data into the registries. And then when should we be doing imaging? I certainly have met patients today alone that have never had an MRI, or don't think they've had an MRI, or haven't had head imaging. They said no, because they knew what the diagnosis was at day 5, so we were good. And now that we're trying to advocate for patients more, I think it could potentially, I can't say with certainty, but as a neurologist, I'm biased, I think it could be useful to have more data for families to make really educated decisions, especially if they're being sedated for other reasons. And when to do an MRI, we know MRIs are different when you're a neonate versus when you're over 3 and more myelination has occurred and the picture is different. So talking with families about that when they decide they want to do imaging. And then why do some patients with trisomy 18, even mosaicism, have intractable epilepsy where others don't have any seizures? So trying to figure out that a little bit better too. Okay, you're next. Slides? I don't see any more slides on this.
Wait, oh, that's
Okay.
Jim's on another part of the desktop. So Megan, like when we did that study, I think we were struck by, even though we knew about kids with intractable epilepsy, when they did the TRICE database, it didn't include that question, so that's why we couldn't address that issue, which we need to address now. I have to figure out why my mouse is not here. I guess I can do an escape there, right? So certainly, last but not least, our speaker, James Hamill, currently in Michigan. Probably when he was in Omaha, had probably the most single vast experience in operating on kids, primarily with trisomy 18 with heart defects. So Jim, welcome. Thank you.
Thank you very much. So I was a pediatric cardiac surgeon in Omaha, and after a period of time, through the first several years that I was there, when patients with trisomy 18 were presented for consideration of surgery, 1 or 2 a year, as is the sort of organic frequency that you might expect. As a cardiac surgeon, I had the liberating advantage of not being burdened by previous medical literature. And so, lacking the knowledge that it was a lethal condition, I just evaluated and treated as it seemed to be appropriate. And so what I guess I'd like to convince you, and I think if you're not already convinced, maybe I won't be able to add anything to it, but there were a lot of people who felt that what was done in this left picture was wrong and unethical. This is an infant who's just recovering from cardiac surgery, got a nice sternotomy and an endotracheal tube. But I knew that this patient could very easily become that patient and could become some of the other young adults and gratifying members of family that you have that you've seen presented here. I'm glad there were 2 speakers interposed between Dr. McCaffrey and myself, because I don't know if I could have followed that act in any way. But, not that it's an act. But, thank you. Okay, so you saw similar data, but after we'd operated on a few of these kids, we started to receive an increasing number of requests for consultation, and starting to be from outside our ordinary catchment area in Omaha. And I talked with some of the other people who actually were pediatricians in my institution, and who also had an interest in the in trisomy, and who had the I think the humility to question the established narrative that was being taught. And they brought this study to my attention, which for me was really sort of a road to Damascus moment. That of the children who survived cardiac surgery and were discharged, this shows median survival. Median survival at somewhat beyond 15 years. And I thought this was, well, just before 15 years. This was extremely eye-opening to me and to my colleagues in cardiology and cardiac surgery. And we sort of started a program, by which I mean we educated best we could the fellow neonatologists, the pediatric intensive care doctors, and anyone else who would listen about this and some of the other literature that you've seen about the potential for a really meaningful duration of life after cardiac surgery and possible utility of it. And we received a lot of requests for consultation, many of which we deemed to be situations where it was appropriate, likely to be beneficial. This shows the development, rapid development of our experience in cardiac operations, that peaking in 2019 with 17 cases before COVID occurred and kind of shut the inter-hospital transfer down and ended ended the avalanche. But To briefly summarize this single institutional experience, over the course of about 2 years, we operated on 33 children. These were selected carefully out of the almost 200 referrals requesting cardiac surgery that we received based on what we thought to be the physiologic state of the patient, which was often much too late, and their likelihood of benefit. But of the 33 that we operated on, the overall survival to discharge was 82%. We did accept, I would say, a much higher risk population than the populations that were reported in, for example, the STS database study, in that many more of our patients were intubated from birth, 50% were mechanically ventilated at the time of surgery, and many of them had single ventricle physiology with or without the possibility of surgically establishing a biventricular circulation at that operation. The experience was that caring for these patients was more complicated and difficult, and their stays were prolonged, as it says. Their average home discharge length of stay was 60 days, and of those who did not make it, they struggled for even longer, over 3 months. And of the group that we operated, I apologize, I can't give you a number for median follow-up, but best recollection, it's about 4 years. And at that follow-up, 64%, or 21 of the 33 patients, were still alive. This was earlier presented, and so I'll just remind you where these numbers come from. This was a review of 8 years of data from 125 hospitals, so 1,000 hospital years of data during which 343 operations occurred. So 0.3 operations per center per year. And most of the operations were in Trisomy 18. And I just wanted to remind you where those numbers came from, because this is, to me, an important number, an important slide, although it's not really observed data, it's projections based on populations. But if you start with the numbers of almost 4 million US births in a year, and the database containing approximately 25,000 total cardiac operations per year, with previously reported data that 10% of those are for patients with trisomy 21. And then looking at textbook information, the incidence of trisomy 21 being 1 in 1,000, incidence of trisomy 18 in live births being 1 in 6,000, trisomy 13 being even less common. Of those, what percent have congenital heart disease? Again, just sort of textbook information. I did subsequently acquire a textbook and read it. Then working from that, the number of kids with Down syndrome who have a heart defect born each year, the number with Tri-18, the number with Tri-13 born each year. Contrasting that with the number of operations that were performed. More operations were performed in children with Down syndrome than the number who were born. So I'm going to surmise, even though it's not probably totally correct, that essentially all children with Down syndrome and heart defect had an operation performed. I know that's a bit of an adventure, but importantly, 6% of children probably born with congenital heart disease and trisomy 18 had an operation, and 9% of those with trisomy 18. So it's hard to know where the attrition occurred between the live birth and not having an operation. We know that, as has been shown earlier here, that having an operation improves the likelihood of home discharge in neonatal admission, and it improves the long-term survival significantly beyond that of purely non-cardiac supportive care. And so there are some children missing here, and I think that through this kind of outreach effort, maybe we can track some of them down. So that's really all I have to present. Thank you.
So Jim, looking at that number of 6%, that 9% for 13, that's pretty close to what Katya mentioned was in her study. That is, in her study of all the kids with heart disease, 7% had surgery. So your estimation, based on prevalence data and everything else, not just actually your data from the FIS
Yeah.
database, so anyway.
I was just wondering, well, I guess I was wondering if from that other study, from the STS study, but it says you can't because you're not looking at all. I don't know if they presented that compared to.
Which study?
Of how many total.
Yeah.
It's, you know, let's say over a year in the STS, how many of those ended up being T13,
Right.
T10. I don't know if that was ever put in that paper.
Anyway, I greatly appreciate and thank all of my colleagues for fabulous presentations. The fabulousness, though, led to us not having time for very many questions. On the other hand, they were just great presentations. But that doesn't mean that I won't accept a comment from the front row or anyone else who had a question or comment.
I'm just wondering, are there any maternal fetal medicine folks that are involved with SOFT? And it seems like we were talking, the endocrinologist sitting next to me, she runs our osteogenesis imperfecta clinic, and a lot of the same themes of prenatal diagnosis and the trauma that is occurring from a very early age to the patient and to their family. So wondering what inroads you've made there, if any, is that something that's happening?
Oh.
I was just going to speak about the experience that I have at my institution. So I'm sure you're going to have something to say about it. But in the sense that we have like a perinatal palliative care group. And I think that, and we have both neonatologists in that group and MFMs in that group. And I, to a certain extent, participate in that as I'm able to. So I think the goal there is to try to address that specific issue. I don't know to what extent we're like super successful at it. And I think that you brought up some really good points, which, you know, I think need to be addressed. But that's how, you know, we're trying to bridge that gap. And one way that I've helped with that is through education and, you know, creating like a resource that could be read, or I'm consulted, you know, to provide counseling for those families. But not everybody will, you know, will come to our fetal care center. So we are definitely not, you know, educating all families. So I think there's a lot that could be done to improve that.
Yeah, I mean, I think it's an important question. I mean, I think we've talked a little bit about SOFT, including trying to find MFMs or OBs to be part of SOFT. I mean, I think that's really important. There, for myself, similar to Katja, I mean, we have a similar situation in our hospital, a big academic center, of course, where we've got a fetal center, and we regularly speak with the OBs and the MFMs about all this. We've been doing this for like 7 or 8 years now, and I think we've actually turned the ship there. The one thing we are not doing is cardiac surgeries, but the attitudes are very different than when I landed there back in 2006. And it's not one person, it's a number of people hearing the message that, you know, maybe what we thought was true is not necessarily true. I think as far as nationally, there is another group out there, and I don't want to mix and match politics here, but the American Academy of Pro-Life OBGYNs has been very open, APLOC, to hearing about trisomy 13 and 18, and that's a fascinating experience. I've presented there several times at their national meetings, and you would think, oh, there's a bunch of pro-life OBGYNs. I mean, first of all, you might think they meet in a phone booth, but it's actually there's a pretty large group. I mean, our meeting last year in Texas was 1,000 people. And so, but it's interesting that still a lot of them see perinatal hospice as the alternative to abortion. And, you know, you know, abortion is reality. I mean, and that's an option for families. And, you know, I totally accept that, but I just wish we would be presenting at least the 3 big options, you know, a little bit more openly and let people perseverate and think about that a little bit. I think we made some headway, but we have more work to do, I think.
So we did have an MFM that was involved in soft came to many meetings, but unfortunately Dr. Byrne is in her retirement phase, and I've invited her to come the last few years. But we also have an OB in San Antonio, who's also the mother of a 5-year-old, and she helped us work on this prenatal book that we call Book for Expectant Parents that our soft leadership knows very much about. But I'll end with this point because it is past 1:30, is that both soft and our collaborative that Ben Wilfond is leading have identified what you're asking as like a really, really key issue. And education being one part of that, but it's even more. So it's not lost, but lost on us, but I can't say we have, you can see the eclectic nature of the group up here, yet we have to go after that stone as well.
Yeah.
Stone is not a good metaphor, sorry. So I thank everyone's attention who did stay with us. Thank you, Tori, for helping us put this together. Thank you, Josh, for every little detail that you worked out, including lunch. And
we do have the recording.